You're welcome to my YouTube channel. I'm Dr. Mercy Kalenzi from the Health Tips Chat Room, and today I want to share with you about shared decision making as regards to healthcare. And if you have not yet subscribed to my YouTube channel, please subscribe. Hit the bell icon down there so that you'll be notified every time I upload a new video. And if you find this video helpful, please like, share, and leave a comment. Thank you. I know some of you are wondering what I mean by shared decision making in healthcare. After all, my doctor makes all the decisions for me. But today, you've got to appreciate what I mean by shared decision making and actually be able to apply it. So shared decision making is the process by which a healthcare provider and the patient discuss together to make decisions concerning investigations and available treatment options and other care plans. So in simple terms, shared decision making is the product of the conversation between a healthcare provider and the patient that helps the patient make an informed consent. I feel it's imperative that we discuss about shared decision making because from my time of experience, I have noted that there is a big gap in involvement of patients in decision making processes in our country and in Africa at large. For instance, a number of mothers I've encountered with the previous history of a cesarean section, only a handful are able to tell you the reason as to why they were operated. Most of them tell you, I don't know why I was operated. And when you try to ask them why they didn't ask their surgeon, most of them will tell you, Doctor, I didn't know that I was supposed to ask. Imagine a case scenario where a patient is scheduled for a total abdominal hysterectomy due to supposedly a pre-malignant uterine lesion, is actually found midway the procedure to have no uterus. I know what you're thinking, and yes, I agree. They could have done a better job at investigating this patient. But leaving this aside, there are two possibilities that could have contributed to this scenario. One, the current team may not have fully engaged this patient in shared decision making about what they wanted to do in this woman's abdomen. Because if they had involved her, maybe she would have disclosed to them that she has no uterus. Maybe they engaged her in the decision making process, but she had no idea that she had no uterus because the previous surgical team never involved her. And that's the reason she was not aware she had no uterus. Actually, this is also a kind of patient who would present to a fertility clinic with complaints of failure to conceive because she doesn't know that she has no uterus. Actually, there are many scenarios I could give, but I think now you understand what we mean by shared decision making and its importance in healthcare delivery. Shared decision making can involve a wide range of procedures like a complex neurosurgery due to a brain tumor to something supposedly as small as taking paracetamol for a headache. So what hinders us from being part of the decision-making process as part of healthcare delivery? Okay, the reasons are quite many, but to highlight a few, there is something called professional gap, whereby a patient knows that a doctor is all-knowing and therefore is entirely responsible for all the decisions that pertain my health. Actually, there are cases whereby a clinician explains to the patient maybe a number of treatment options, but when you ask a patient, what do you choose? And this patient will tell you, doctor, you choose for me. You're the one who knows. But you need to be able to be responsible for all the decisions that pertain your health. It is very true that a doctor, a clinician, your healthcare provider will help you to make a good decision. But that's why we have what you call informed consent. You're supposed to consent for anything that is going to happen or to be done to your health. So something else that could hinder our decision-making process is culture and regional beliefs. Taking an example of Jehovah's Witness and blood transfusion. Imagine admitting a 2-year-old baby with severe malaria and complicated with severe anemia. Such a baby would benefit from blood transfusion. But talking to the mother, she declines. So you see, she's declining because of her beliefs. So such a belief would come in the way of shared decision-making process, especially if the prognosis of this baby depended on blood transfusion. So another culprit that would hinder shared decision-making is family social support. Taking an example of our African tradition whereby most of our patients is either a child being taken care of their parents or the elderly being taken care of their children. So in this scenario, you find the patient deserves to be admitted in the hospital, but because it is their parents that are taking care of them and maybe have fixed programs, they have some interviews to do, they have some jobs to go for, they decide to decline the admission because they are busy, and this hinders the patient's decision making. Even when the patient feels very unwell and maybe they would still want to be in the hospital, but they would not make that decision because the caretaker is declining. Some other scenarios is why you find that maybe a family has got a family social history or a familial disease like epilepsy, and maybe because one of their family members is a big person in the government, they decided to hide that history. And when you try to look at the patient's presentation and examination, you clearly see that most likely that's your diagnosis, but they try as much as they can to hide that information just because they don't want to be embarrassed. So it will actually inconvenience a patient's decision making because they are not going to take maybe those drugs as prescribed because their family is not supporting them, or else they are not going to tell you the truth because the family is against it. So that inconveniences the decision making process. So another example where family social support negatively affects our patient is considering a 20-year-old male that comes to the hospital with a testicular torsion that cannot be salvaged, and you consent this gentleman with the mother that he will have to benefit from an orchidectomy. But the mother declines because of her fears and maybe some myths that she has heard. She tells you, you know what, doctor? I was told if somebody does an orchidectomy, they will never produce. And if they produce, then my son will maybe have one sex of children. So you realize in this scenario, his son is going to fail to make a decision because the mother is not supporting the procedure you're going to do. So in this scenario, it frustrates the patient on really how they can make a decision for themselves because they entirely depend on their parents for psychosocial support and, of course, financial support. So I would also want us to appreciate something about shared decision making in relationship to time. How does time affect our decision making, or how does time affect the outcome of our decision making process? Me and you understand that there are times when we have emergencies and we have got to make decisions in a short time. But of course, there are people who you try to explain to that, in this and this scenario, you need to make your decision urgently if we are to save your life. So people in there are hesitating, and I would want us to appreciate why are they hesitating and how do their hesitation affect their outcome. Situations like an emergency section needs urgent decision making. For instance, the time a term pregnant mother takes to consent for a cesarean section will determine whether she will have a healthy baby or she will have an unassociated baby who ends up with cerebral palsy and will be dependent for the rest of their life. And at worst, such a mother, if she takes longer time to decide, she can even have a fresh stillbirth. And by the way, this is a very painful case. A mother carrying a pregnancy for 9 months, but because she would not make a decision in a short time, maybe because she's waiting for the husband, maybe because she has a lot of fears, she ends up with a fresh stillbirth. It's a very painful scenario. So the same applies to conditions like metastatic cancers, where we have cancers of the breast, cancers of the prostate, cancer of the penis, cancer of the cervix, whereby if you do not make a decision to be operated or be worked on in a particular period, then it would change the outcome of everything about you. And also we have other conditions that are non-malignant, like status epilepticus, acute hemorrhage, where we have things like tension pneumothorax, and you would go to make a decision in a shortest time so that you can at least save your life or save somebody's life. We need to be able to discern when our healthcare providers are requesting us to make urgent decisions, because as soon as we make the urgent decision, it will help us have better outcome of our conditions. So how can we improve shared decision making? We have already looked at things that hinder our decision making. And now, how do we improve? And this goes to healthcare providers as well as our patients. So there are 3 practices that we should observe when we are doing shared decision making process. When we are in this process, there are 3 things that we should observe. So one thing we need to observe as healthcare providers is patient education. As a healthcare provider, one thing that you need to think about when the patient is making the decision is patient education. The patient will not be able to make a better decision if they do not understand their current condition, if they don't understand available treatment options, and of course, if they do not understand some of the side effects of your treatment modalities, they can't make a decision. So patient education is a key factor. Communication skills are an important factor. It's a very important skill that all the healthcare providers employ if a patient is to make a good informed consent. I also like using what we call patient teach-back method. In patient teach-back method, I deliver information to the patient regarding the condition they are going through, and then ask them to share the same information back to me. And this achieves 2 goals. So the patient is able to synthesize the information which you have explained to them as they teach it back to you in a way that makes sense to them. And this helps you and also helps the patient in information retention. So this allows me to assess whether the patient has got loopholes in understanding the information given to them, and also assess if they can recall information correctly. A second goal is it helps us to assess if there are loopholes in understanding the information explained to the patient, and also if the patient really recalls the information that has been explained to them. With the 2 goals above, it gives us clinicians a chance to review some facts and help the patient understand better. So let's not forget that the patient is an expert on the patient. So the clinician needs this information. And also, the clinician is an expert on the disease. And so the patient needs this information. So if they both combine, they can do their best in finding an approach to a particular clinical problem. So something else that would help patients to make their decision is understanding their culture and personal preferences. So it is important for healthcare providers to understand patients' culture and regional beliefs. As for us, we get many patients with different background, different cultural beliefs, different Christian faith. So it's difficult. Some of them it's difficult to make some healthcare decisions, as it may differ and or sometimes contrast with their belief. So we need to assess these values at the start of our healthcare delivery, so we know where to base this patient or how to help them. So healthcare providers should reframe their idea of making treatment decisions. Making a healthcare decision is not always what the healthcare provider wants, but actually what would complement their patient's life circumstances. So considering a mother who's refusing blood transfusion for her child, don't always speak to her harshly, do not judge her. Sometimes it will be because of her culture and her religion. So instead of judging such a mother, help her alleviate her fears, and in the long run, she might consent for blood transfusion. So the last thing that is helpful actually in shared decision making is engaging family and caretakers. And from experience, I've noticed that patients and families that are partners in planning their outcomes are actually very good. Also, clinicians need to understand patients' preferences as far as family involvement is concerned. Actually, some patients may not prefer high levels of family involvement in their treatment. So in some scenarios, clinicians encounter families and patients who have conflicting wishes, and in such scenario, we prioritize the patient's wishes. But remember, in such cases, families are the ones that support our patients with finances and emotional support. So we need most times to make sure we harmonize with the two parties so that we have the best outcomes for our patients. I hope you have been able to understand what we mean by shared decision making in healthcare system. Also, have been able to appreciate decision making in urgent or emergency situations, the challenges that we face during decision making, and how we can actually overcome them. Thank you everyone for watching. I hope this video has been helpful. Please like, share, and if you're watching for the first time, please subscribe. Thank you for watching.